Hello, in this video we are going to learn the anatomy of anterior abdominal wall. The anterior abdominal wall is a musculo-aponeurotic sheath which covers the abdominal cavity. It is formed by both the muscles and some aponeurosis. Before going to see the details of the anterior abdominal wall, let us see some of the surface landmarks of anterior abdominal wall. What are the extensions of anterior abdominal wall? It extends from the thoracoabdominal diaphragm above, and below we have the pelvic diaphragm. From the thoracoabdominal diaphragm here, which separates the thorax from the abdomen, and here below at the floor of the pelvis we have the pelvic diaphragm. Okay, posteriorly we have the posterior abdominal wall. Anteriorly we have the anterior abdominal wall, that is the boundary of the abdominal cavity. Okay, now let us see some of the surface landmarks. The first thing which is visible on the anterior abdominal wall is there is a bony landmark, that is the xiphoid process. We have the xiphoid process here, xiphoid process. Remember, xiphoid process lies in the median plane at the apex of the subcostal angle. So this is the subcostal angle. So the angle which is formed here is a subcostal angle, and remember this xiphoid process lies at the level of 9th thoracic vertebra, T9. Remember this point, T9. So this xiphoid process lies at the level of 9th thoracic vertebra. Then, so this is the costal margin. So we have the costal margin here. So costal margin is mainly formed by the 7th, 8th, 9th and 10th rib. We have the 7, 8, 9 and 10th rib. So remember, this costal margin is formed by the costal margin, which is formed by the 7th, 8th, 9th and 10th ribs, or the costal margin or the ribs. Now then, and the angle which is formed here is known as a subcostal angle. This angle is the subcostal angle. You have the subcostal angle. Now below we have the anterior superior spine, then we have the pubic symphysis, and there is the pubic symphysis and the pubic tubercle. Then again we have the iliac crest. So here we have the iliac crest. This iliac crest forms the lower margin of the anterior abdominal wall. Then we have the anterior superior spine and some of the other landmarks. We have the pubic tubercle. Then here comes the pubic symphysis. Okay, and this particular area, which is a ligament is formed, that is known as the inguinal ligament, and superficially it is also known as a Poupard's ligament, Pouparts, Poupard's ligament. And on the surface of the body between the anterior abdominal wall and the thigh is known as the fold of groin. This area is known as the fold of groin. Okay, now let us see the layers of anterior abdominal wall. What are the layers of anterior abdominal wall? Superficially we have the skin. Below there is a superficial fascia. Then there are some muscles are there, 3 muscles, and some other layers are there. Okay, so let us see one by one. So we have the skin, then comes the superficial fascia, then there is a muscle called external oblique abdominis muscle. Deep we have internal oblique abdominis. Deep to that we have the transversus abdominis, and below that there is a fascia. That fascia is known as the fascia transversalis. Then comes the extraperitoneal connective tissue, and the last one we have the innermost layer is the parietal peritoneum. Okay, then so we have once again we have the skin. Then the superficial fascia has got 2 layers. There is a superficial fatty layer and deep membranous layer. That is, fatty layer is called campus fascia and the membranous layer is known as a scarpa's fascia. Okay, so we have the skin. Then comes the superficial fascia, has got 2 layers, superficial fatty layer and deep membranous layer. Then there is a external oblique abdominis, internal oblique abdominis, transversus abdominis, fascia transversalis, extraperitoneal connective tissue, and the parietal peritoneum. All together we have 9 layers of abdomen. Remember, 9 layers of anterior abdominal wall. Anterior abdominal wall. Okay, so in this diagram again you can see, so we have the skin. Okay, see, we have the skin, first layer, then there is a superficial fatty layer, we have the second layer, that is a campus fascia, the third one is a scarpa's fascia, then we have the anterior oblique abdominis muscle, external oblique abdominis, internal oblique, transverse abdominis muscle, then there is a fascia transversalis, extra peritoneal connective tissue, and finally we have the peritoneum. Total 9 layers are there. Remember the 9 layers of abdomen. Inside this is the peritoneal cavity. Peritoneal cavity. Peritoneal cavity. For the descriptive purpose, the anterior abdominal wall is divided into some regions by some lines. Okay, there are some planes are there. So now we are going to see what are the planes of anterior abdominal wall. The first one is known as the transpyloric plane. Transpyloric plane. Let us see. Here we have the this is the transpyloric plane. Okay, so how will you draw the transpyloric plane on the surface of the body? Okay, first you make a line from the jugular notch. You know there is interclavicular. Here we have the two clavicle. Interclavicular, that is jugular notch. From the jugular notch to the pubic symphysis, if we make a line over here and and a midpoint of that particular line, okay, and that is known as is transpyloric plane. Transpyloric plane, remember these levels of transpyloric plane passes through the tip of the 9th costal cartilage and the lower border of the L1 vertebra. Lower border of L1, 9th costal cartilage, tip of 9th costal cartilage anteriorly, and posteriorly we have the lower border of L1 vertebra. Lower border of L1. Remember these two points. Then, and roughly you say it is a hand breadth below the symphysis joint. So here we have the symphysis joint. From here a hand breadth below the symphysis sternal joint. And what are the importance of this transpyloric plane? Remember, pylorus of the stomach. At the transpyloric plane, what are the structures seen at this level? Okay, so we have first one is the pylorus of the stomach, hilus of the kidneys, fundus of gallbladder, origin of superior mesenteric artery, and lower end of spinal cord. So these are the structures present at the level of transpyloric plane. So once again, what is transpyloric plane? Transpyloric plane is a midpoint of a line joining the jugular notch to the pubic symphysis. Okay, anteriorly this line passes through the 9th costal cartilage, and posteriorly we have the lower border of the first lumbar vertebra. Okay, and roughly it is a hand breadth below the symphysis sternal joint. What are the main structures? We have the pylorus of stomach. Remember, hilum of kidneys, fundus of gallbladder, origin of superior mesenteric artery, and lower end of spinal cord. Okay, and normally the transpyloric plane is used for examinations. Okay, because it has got some this importance. Remember this point. Next plane is the subcostal plane. Subcostal plane. You know, costal. You know the costal margin. Costa means ribs. Okay, so that means we have the costal margin. We have the right costal margin here. This is the thought process, and here we have the left costal margin. So the line passes below. This is known as the subcostal line. Subcostal. So here you can see the subcostal. So we have the two costal margin. Remember, the subcostal margin passes below the subcostal line passes below the costal margin. Remember, it passes through the lowest part of the 10th rib and the lower border of the L3. Okay, so the transpyloric plane was passing through the 9th costal cartilage, and this plane is passes through along the lower part of the 10th rib or along the 10th rib, and the vertebral level is this was L1 and this is L3. Remember this L3. And there is one more important plane that's called transtubercular plane. So transtubercular, you know the tuberosity of iliac crest here. Okay, so this plane passes through the tuberosity of tubercle of iliac crest. Okay, tubercle of iliac crest, and this is passes along the body of the fifth lumbar vertebra. So we have three transverse plane, that is the transpyloric plane, transpyloric, then we have subcostal, and the next one subcostal, and there is a transtubercular. Okay, easy to remember the vertebral level L1, L3 and L5. L1, L3 and L5. Remember this one. Okay, and there is a horizontal line, that is a mid clavicular line. We have the mid clavicular line passes through the, we have the clavicle here, middle of the clavicle to the mid inguinal point. This is the mid inguinal point, mid inguinal point. You know the mid inguinal point. Okay, so middle of the clavicle to the mid inguinal point. So that is known as the mid clavicular line, mid clavicular line. The anterior abdominal wall is divided into different quadrants. Anatomically, we have 9 quadrants are there. What are the planes dividing? Here we have the transtubercular plane we have here, and here we have the transpyloric plane. This is a transpyloric plane, transtubercular plane, and we have the left midclavicular line and the right midclavicular line. Okay, so we have 9 regions. So what are they? Epigastrium, umbilicus, hypogastrium, right hypochondrium, left hypochondrium, right lumbar, left lumbar, right iliac and left iliac region. So we have anatomically 9 regions are there. There are 9 quadrants anatomically. So we have anatomically 9 quadrants are there. 9 quadrants are there. Okay. Now, and clinicians are using, they are describing different this one. So here you have, normally they use 4 quadrants. We have the right upper quadrant, left upper quadrant, right lower quadrant and left lower quadrant. They uses a transumbilical plane. Transumbilical passes through the umbilicus. If you make a transumbilical plane and the midline, so we get 4 quadrants: right upper quadrant, left upper quadrant, right lower quadrant and left lower quadrant. Okay, then again there are 3 zones. Some are using 3 zones. We have, there is the upper zone, that is here we have this constitute the upper zone. So here comes a middle zone and this is the lower zone. You can see upper zone is formed by epigastrium, right hypochondric, left hypochondric. Middle zone is the umbilical region, right and left lumbar, and the lower zone hypogastrium along with the right iliac and left iliac fossa. They are the quadrants clinically. 2 more structures we are going to see. One is the linea alba. You know the linea, 2 more terminologies we are going to see. One is the linea alba. So linea alba is a midline structure, a white line at the middle of the passes through the middle of the anterior abdominal wall, that is called linea alba. Another one is a lemia semilunaris, lemia semilunaris. Okay, so there is a muscle on either side of the midline called rectus abdominis muscle. Okay, the lateral border of the rectus abdominis muscle, lateral margin of the rectus abdominis is known as the linea semilunaris, linea semilunaris. And one more line we have already seen, the linea alba. Linea alba is a wide line, is a midline, middle of anterior abdominal wall. Okay, so 2 more lines we have seen, that is a linea alba, another one is a linea semilunaris. 2 more new terms we are going to see, that is the McBurney's point. First one is McBurney's point, another one is the Murphy's point. Okay, so what is the McBurney's point? See here, this is the anterior superiliac spine and there is the umbilicus. If we make an imaginary line connecting the anterior superiliac spine, so we have anterior superior iliac spine and umbilicus. That line is known as a spino-umbilical line. Spino-umbilical line. Okay, so what is McBurney's point? The point between the medial two-third and the lateral one-third of spino-umbilical line. So we have the medial two-third. This is the spino-umbilical line, medial two-third and lateral one-third of this spino-umbilical line is known as the McBurney's point. McBurney's. What is the importance actually? So we have the base of vermiform appendix. Base of vermiform appendix lies at this level. Lies at this level. And what is the clinical importance actually? So we have the maximum tenderness, maximum pain or tenderness felt at this region during appendicitis. Okay, so that is the McBurney's point. Another one is the Murphy's point. What is Murphy's point? Okay, so Murphy's point is, you can see, what is the name of this one? This is a linea semilunaris. Okay, so the point or between, so here we have the ninth causal cartilage, right ninth causal cartilage and the linea semilunaris. So the junction between a line passes through the right ninth causal cartilage and the linea semilunaris. So that is known as the Murphy's point. What is the importance actually? You can see the fundus of gallbladder lies due to that. Fundus of gallbladder lies deep to this point, and this is the area of maximum tenderness during cholecystitis. This is the inflammation of gallbladder. During inflammation of gallbladder, the patients feel pain at this Murphy's point. Okay, and again it is a meeting point of linea semilunaris with the right ninth. Remember the right ninth causal cartilage, right ninth costal margin. It corresponds to the tip of the ninth causal cartilage. The fundus of gallbladder lies deep to this point. Palpation of Murphy's sign while the patient takes deep breath elicit tenderness in case of acute cholecystitis. During acute cholecystitis, okay, so when the patient takes deep breath, okay, so this area the patient feels pain. Okay, that was the surface landmarks or the surface structures which is seen on the, or which is felt on the anterior abdominal wall. Now let us discuss the layers of anterior abdominal wall one by one. The first one is the skin. You know the skin which covers the surface of the body. Okay, so so here in the skin, so now so we're going to see a special term that is known as the Langer's line. So what do you mean by Langer's line? Okay, so this Langer's line, you know the skin has got two layers. We have the epidermis and the dermis. Okay, you already familiar with the layers of epidermis. Okay, in the dermis there are some transversely running structures that are the collagen fibers present. So okay, dermis has got horizontal lines produced by the bundles of collagen fibers. So these are the collagen fibers. You can see bundles of collagen fibers are present in the dermis. Okay, and these collagen fibers, the orientation or the direction of these collagen fibers, you can see that in the anterior abdominal wall they are horizontally running. Okay, so here these are the alignment of these collagen fibers. Okay, then so now what is the surgical importance of this Langer's line? So this particular direct arrangement is known as the cleavage lines or Langer's line. What is surgical importance? An incision along the cleavage line will heal as narrow scar. That means if the surgeon gives a vertical incision or a incision like this, so it cuts the maximum number of collagen fibers, so there is a maximum scar. So if an incision along the or parallel to this particular Langer's line which produces minimal scar, that's the surgical importance of this maximum Langer's line. An incision along the cleavage line will heal as narrow scar, while that one crosses the line will heal as wide scar. It produces a wide scar here. So hence horizontal incisions are more preferred in abdominal surgery. So in most of the abdominal surgeries, the horizontal incisions are preferred for minimal scar. then then you can see, just look at this picture, you're very familiar, you might have seen these are the stretch marks, normally very common word, stretch marks. What exactly the stretch marks? Okay, so here in this picture, that condition is called linea gravidarum. Linea gravidarum. Gravid means heavy. It's a Latin word, means heavy. Okay, linea gravidarum means irregularly branched white lines on the lower abdominal skin of pairs women due to undue stretching of the anterior abdominal wall by the gravid uterus. Gravid means heavy. Okay, during pregnancy, what happens actually, the heavy uterus produces more pressure on the anterior abdominal wall, so there is a stretching of the skin. So the stretching of these collagen fibers produces stretch marks. Okay, so these stretch marks produced by the heavy uterus during pregnancy or multiparous women, so that is known as a linea gravidarum. So normally asked for examination, 2 marks question, linea gravidarum. Linea gravidarum. A structure which is seen on the skin of anterior abdominal wall is the umbilicus. Umbilicus, it's also known as the omphalos, the term omphalos. Okay, so what exactly this umbilical cord? It's a normal scar which is the remnant of umbilical cord. Okay, so this is a place where the umbilical cord was attached. That is the umbilicus. So remember the position of this umbilicus in adult. It is present between L3 and L4. You can see the third lumbar vertebra, and here we have the fourth lumbar vertebra. It presents between L3 and L4. It is lower in infants and in elders. In case of elders and infants, it is lower case. Okay, and one important structure, when the point you should remember is umbilicus is innervated by the 10th spinal segment, T10. So remember by heart this point, umbilicus is innervated by the 10th thoracic spinal segment, 10th thoracic spinal, and umbilicus is said to be having a white watershed line. Okay, so what exactly the watershed line is? So we have the spino-umbilical line, there is an transumbilical plane is there. Okay, the lymphatics, as well as this is the lymphatics as well as the venous drainage. Okay, in case of lymphatics and venous drainage, the umbilicus is said to be having, or umbilicus is called as a watershed line. So here we have the umbilicus. Okay, so this is a transumbilical plane. So above and below the lymphatic drainage, this is a lymph and the venous drainage. Okay, below the umbilicus it is drained downwards, and above the umbilicus it is drained upwards. That is the lymphatics and venous drainage. So that is why the umbilicus is known as watershed line. Then the umbilical has got some embryological significance. Okay, so we have already seen that umbilicus is the place where, so we have the umbilicus, and out exteriorly we have the umbilical cord. Umbilical cord is attached. Umbilical cord. Okay, so umbilical cord is attached at the umbilical area. So what is the embryological significance of this particular umbilicus? Okay, that means during the embryonic stage there is something called folds of embryo. There are 4 folds are there. There is a head fold, there is a tail fold, and 2 lateral folds. So 4 folds. So we have, suppose this is an embryo, trilaminar embryo. Okay, so here we have 2 foldings like this. You might be knowing all these things, right? So this is the head fold, tail fold. At the same time 2 lateral folds also is there. Okay, so umbilical is a place where all the 4 folds meets at this one. That is, so we can draw like this. So we have the head fold over here. You want 2 lateral folds. This is a tail fold, and this is the lateral fold. Okay, so umbilicus is a gap. A gap is formed at the meeting point of these 4 folds. So that is known as an umbilical ring. Remember the umbilical ring. So what is umbilical ring? Umbilical ring is a gap at the umbilicus during embryonic period. So we have, remember this umbilical point. So umbilical ring is there. Okay, and some structures are passing through the umbilical ring. So first one is the midgut loop. You can see the foregut, midgut and hindgut. So the midgut lobe passes through the umbilical ring. Okay, so during the course of development, what happens actually, the midgut lobe passes through the umbilical ring, which comes out of the proper embryo. Okay, so that is the vitello-intestinal duct. So that particular part is known as the vitello-intestinal duct. Vitello-intestinal duct passes through the umbilical ring, and later on this what happens actually, the midgut loop, okay, the midgut loop will go back. Okay, so why the midgut loop comes out? Because it helps, or it because of the development of the liver and other structures. So when the liver and other structures develops in the abdominal cavity, what happens actually, this midgut loop comes out. So once the development of the other structures completes, so the midgut loop goes back. So that particular extension is known as a vitello-intestinal duct. Again we have, this is a foregut, here comes a midgut, and this is a hindgut. So from the hindgut there is an extension that is known as the allantois, so somewhat like this. So here if I draw here, so we have the foregut, then we have the midgut, and here we have the hindgut. From the hindgut there is an extension, so that extension is known as the this is allantois. Okay, the proximal part of allantois. From this area what happens, urinary bladder develops from the proximal part of this particular allantois. Okay, so two important structures we have seen at the umbilical ring, that is the vitello-intestinal duct, then next one is the allantois, then we have the umbilical vessels are there. So we have one umbilical vein and two umbilical arteries are there, two umbilical arteries and one umbilical vein. So these are the structures present or passes through the umbilical ring. So what are structures? If you draw, this is the umbilical ring. So first structure what we can see is this is the vitello-intestinal duct is passing through. Then we have the another structure is the allantois, and we have one umbilical vein and two umbilical arteries. So we have 1 2 3 4 5 structures are present at the umbilical. Okay, so this particular so here if again I'm drawing the embryo proper, so we have the foregut, then we have the midgut, this is a hindgut, this is the urachus or the allantois. Okay, what happened to allantois? So it is somewhat like this. So we have the foregut, it's a midgut, this is drawing like this particular part from the urinary bladder. Okay, so once the urinary bladder is completed, this particular part is called as the urachus. Okay, and the urachus opens into the umbilical ring. Okay, that is the urine which is produced by the embryo will be when excreted through the urachus is given to the umbilical cord, and the fecal matter which is produced will be passes to the vitello-intestinal duct. Okay, then what is the fate of these structures after the birth? So urachus, okay, that will forms the median umbilical ligament. So here we have the medial, this was the urachus, this is you can see the urinary bladder is formed here. So once the urinary bladder is formed, there is no need for this particular communication, so this communication will get obliterated and forms the median umbilical fold. Then we have the umbilical artery was there. Okay, so we have two umbilical arteries were on either side. So these umbilical arteries will be converted into medial umbilical fold. So here one the left side, then there is one more right side. This is the obliterated umbilical artery. Obliterated umbilical artery will be forming the medial umbilical ligament, and we have what umbilical vein was there. This umbilical vein will be converted into ligamentum teres, which is connecting the umbilicus to the liver. In the there is an obliterated structure which is present present between the umbilicus and the liver. Okay, that is known as a ligamentum teres. Now, so there is a term is called Meckel's diverticle. What is Meckel's diverticle? Okay, so remember we have already discussed this diagram, that is a vitello-intestinal duct. So vitello-intestinal duct is an extension of the midgut. This is the midgut. okay, through the umbilical ring. Okay, so what happens actually, so during the course of development, okay, so this will go back to the abdominal cavity, this vitellointestinal tract or this midgut loop will go back to the abdominal cavity. Okay, if this particular structure does not go back to this umbilical cavity or it persists in adult, so that is known as the, it makes a diverticulum, that is known as the Meckel's diverticulum. This is a midgut loop, this is the future umbilicus, okay, and this is the persistent vitellointestinal tract, persistent vitellointestinal tract, that is known as the Meckel's diverticulum. Meckel's diverticulum. Okay, there is something called rule of two. Rule of two in relation to this Meckel's diverticulum. It occurs in 2% of the subject. It is present 2 feet from the ileocecal junction. In 2% of the cases it is symptomatic, and 2:1 male prominence. Okay, more in case of male. And sometimes this structure or this Meckel's diverticulum causes intestinal obstruction. Intestinal obstruction. So what is in Meckel's diverticulum? Meckel's diverticulum is the persistent vitellointestinal duct. Persistent vitellointestinal duct. Now, what are the conditions associated with the persistent vitellointestinal duct? The first one is called, vitellointestinal duct. Okay, we have seen that. See, I am drawing again. So we have the foregut. This is the midgut. This is a hindgut, foregut, midgut, hindgut. This is, urachus or the allantois. Allantois. This is the vitellointestinal duct. Okay. Then what happens actually? This this persistent vitellointestinal duct leads to Meckel's diverticulum. Okay. So there are different conditions associated with that. First one is known as vitelline fistula. Vitelline. Fistula means, what is fistula? It's an abnormal communication. Abnormal communication. That is the fistula. Okay, so here what happens actually in the vitelline fistula, that is there is the communication is persistent communication. Okay, so that is called vitelline fistula. What happens actually, if this fistula or this communication persists, the fecal matter which is produced in the in the midgut will pass us through the umbilicus, so that is known as a fecal fistula. Fecal fistula. Another condition, if the allantois persist, persistent allantois, what happens, the urine will drip through the umbilicus, so that's called urinary fistula. Urinary fistula. Okay, another condition is called vitelline cyst. You can see vitelline cyst. Here what happens actually, there is no communication, but the communication is obliterated, but it makes it forms a cyst in between. That's called vitelline cyst. So here you can see there is no communication, there is no fistula, but a cord-like appearance, like a vitelline cord. And here you can see Meckel's diverticulum. What is Meckel's diverticulum? So diverticula is present, but it does not communicate with the cavity or the umbilicus. Okay, that is a Meckel's diverticulum. So here we can see Meckel's diverticulum along with the cord. These are the different anomalies of vitellointestinal duct. Now, I told you during the beginning of the 6th week of intrauterine life, the rapid elongation of the gut and the increased liver size reduces the intra-abdominal space, which pushes the intestinal loop out of the abdominal cavity. I already told you. Okay, so during 6th week, what happens actually, the elongation of the gut as well as a formation of liver. Okay, so it pushes the midgut loop out of the abdominal cavity during 6th week. Around 10th week, what happens actually, this intestine returns to the abdominal cavity. It will go back to the abdominal cavity. Okay, and if it does not happen, if it did not go back, what happens actually, the persistent loop, okay, after the closure of the umbilical ring. So this persistent loop, which is found to be out of this umbilical ring, so these conditions is known as the exomphalos or the omphalosil. Exomphalos or omphalosil, that is the persistent gut loop. Okay, which is seen at the umbilicus, so that is known as the exomphalos. So there is a normal question asked in examination is referred pain of appendicitis is felt at umbilicus. Referred pain of appendicitis is felt at umbilicus. What is the anatomical basis? Example, you may ask anatomical basis. Give what is anatomical basis? Give reason. What is anatomical reason? The pain which is produced by the vermiform appendix. Okay, there is a initial visceral pain by the distension of the appendicular lumen is carried by the sympathetic fibers. The sympathetic fibers carries the sympathetic fibers, and the sympathetic fibers enters the 10th thoracic segment, T10 of the spinal cord. Then it passes through the spinal cord and reaches the brain. Okay, again you know that the umbilicus is also supplied by the 10th segments. Okay, so from here the reflex reaches going back when it reaches a T10 segment. Okay, from the T10 segment the pain fibers, okay, it is going this one towards umbilicus, appendicitis, and also to the umbilicus. So that is the reason, because of the same innervation, same segmental innervation, so the pain of the vermiform appendix normally initially felt at the umbilical region. That was some of the informations about the anterior abdominal wall. So the rest of the details of anterior abdominal wall will continue in the next video. Hope you understood the video. If you like the video, please subscribe, share it with your friends. Thank you.